Hello, thanks to everyone who's joined today. As the title suggests, we're going to be talking about trauma-informed care in early intervention in psychosis. Next slide, please. To introduce myself, I'm Peter Carter, a psychiatrist and joint lead for NELFT EIP, a role I share with Miriam Fornells-Ambrojo, who's a consultant clinical psychologist and assistant professor at UCL. We also have Dr. Mel O, who's a clinical psychologist with us in NELFT, and Ruby Rathbone unfortunately can't be with us today, but she's done a lot of the work in helping prepare this presentation. Next slide, please. So to give you an idea of the structure which will follow today, we're going to start with some definitions just to orientate us to the area we're discussing, and a couple of polls just to get you thinking about your work now. And then I will talk through the case presentation that Ruby prepared. Miriam will talk through some of the underpinning theory, and then Mel will help us link the theory and the case presentation together. We'll have a longer discussion at the end, but we'll have some time for Q&A in between each of the presentations. Next slide, please. Learning objectives for today are for you to understand the principles of trauma-informed care, to understand the ways in which psychosis and its treatment can contribute to trauma, and for you to be able to incorporate principles of trauma-informed care into your clinical practice. Next slide, please. A disclaimer, which is that this is a fictitious case based on our combined extensive years and experience of working with similar clients in EIP, and any similarities to true patients are coincidental. And also, just with any discussion of trauma, some of the content can be difficult. Next slide, please. So the first poll, if we could launch it, please. To what extent do you understand the concept of trauma-informed care? I think that's enough time. We can show the results from the poll, please. So I think that tells me that very few people are entirely confident with it. Quite a lot of people are somewhat, but more people are much less confident. Thank you. And next slide, please. So first, just to define trauma, and although it's a word that we would all use, I think in this context we need a little bit more definition. So it refers to a wide range of traumatic, abusive or neglectful events or series of events which occur in childhood, commonly referred to as adverse childhood experience, or as an adult. Their experience has been emotionally or physically harmful or even life-threatening. And whether an event is traumatic depends on our own individual appraisal of it and how it impacts on our emotional, social, spiritual and physical well-being. And we are all affected by traumatic events in different ways. Next slide, please. So in thinking about traumatic events, we have 3 E's: the event, how it is experienced, and what are its effects. So 3 E's. Next slide, please. So then a definition of trauma-informed is the ability to recognize when someone may be affected by trauma, to collaboratively adjust our work to take this into account and respond in a way that supports recovery, does no further harm, and supports their resilience. Next slide, please. So we had 3 E's for defining trauma and 4 R's for defining trauma-informed care. to realise how common the experience of trauma is, to recognise the different ways that trauma can affect people, to respond by taking account of the ways that people can be affected by trauma to support recovery, and to resist re-traumatizing and offer a greater sense of control, empowerment, and collaboration. And throughout all of this, I've added a fifth R, which is the central importance of relationships. Next slide. So a second poll, how much do you currently work in a trauma-informed way? And if you can show the results from that, please. So again, quite a mix, perhaps a slightly more clustered towards the sometimes or most. Thank you for that. And next slide, please. So as I said, Ruby can't be here today, so I'm going to run through the presentation that she has created. And that's of our patient P, who's an 18-year-old Sri Lankan female who's been in the UK since the age of 11 and lives in a group home. Next slide, please. So she was born in Sri Lanka, as I said, and grew up with her mother and cousins, maternal cousins, and her father lived in the UK and was back and forth between Sri Lanka and the UK because of his work as a business owner. P has very happy memories of him, describes him as quite respected in the community. But unfortunately, he had a heart attack while driving, which led to a road traffic accident and his very sudden and premature death. Next slide, please. And her life changed progressively after her father's death, and her mother was immediately affected financially. But over time, her own mental and emotional health clearly suffered as well. Her mother was perceived as stopping caring for P, becoming physically abusive. And at times, P can remember locking herself in her room to avoid conflict and abuse from her mother. Her mother started talking to other men, and P remembers these men as often being unkind to her. At age 8, their house was burgled, and she clearly remembers when she was woken from her sleep and armed men came into the house and stole things from them. And they stole all their material wealth. She remembers her earrings being ripped from her ears, and when she was trying to shout for help, she was punched and knocked unconscious. And around this time, her mother moved again, and she remembers several moves of accommodation and involvement with several men, all of whom were abusive and harmful to her. Next slide, please. And at the age of 10, she was sold as a child bride to a man much older. And on the flight to the UK, other passengers clearly became concerned for reasons we're not clear of, but she was taken into the care of social services on her arrival in the UK. She spent 2 years in foster care, and she remembers this as quite a happy time. But the wider family and the cousins decided that they would rather that P lived with her. But unfortunately, that did not, although it was with her consent and the support of social services, it seems that it had a rather more exploitative framework to it. And they were abusive to her, they were blaming her for things that had happened and implying that it was all her fault. Next slide, please. Unfortunately, one of her cousin's friends raped her at around the age of 15. And also her education was extremely difficult, and she remembers being severely bullied when at school. And it was around that time that she was introduced to smoking skunk, and she found this as particularly helpful. It allowed her to calm her emotions. It allowed her to remove herself from some of the more difficult thoughts and feelings that she was experiencing. This culminated, the experience of the assault and the problems in school culminated in her taking a paracetamol overdose and her first contact with mental health services. And this was distinctly low intensity. And some months later, she took a second, much larger overdose that required treatment with a NAC infusion while in hospital. And around this time that Children's Social Services were more closely involved, and she moved to a new foster home. And while this was supportive, it was also a much more strict environment with a strict curfew, strict discussion and explanation of her whereabouts and where she might be moving to. And this culminated with her increasing her use of skunk. Next slide, please. And in keeping with her use of skunk, she gradually began to express concern about her mother, who was actively cursing her from Sri Lanka. She'd had no contact with her mother at all. She became distressed, hostile, not sleeping for several days, and this culminated in her presentation to A&E and admission under Section 2. This was very short. The symptoms seemed to resolve spontaneously, and she was able to move this time initially back to the same care home, but over the coming months to a different care home where she remains today. And she describes that environment as much more validating, supportive, and encouraging. But throughout that time, she continued to use skunk, and she showed little interest in reducing. On the other hand, she seemed to increase it. And 4 months after the first admission, she was in hospital again. Unfortunately, the symptoms didn't resolve, and she was started on an escalating dose of olanzapine, and within only 3 weeks, she was on 20 milligrams. Unsurprisingly, she developed side effects from that. She had weight gain, which went from 60 kg to 75 kg, 25% gain. Her prolactin levels were over 1,000, and she had galactorrhea. And so she was switched quite quickly to aripiprazole, with which the side effects from the prolactin and the weight completely abated. She turned 18, and because she was with EIP, there was minimal disruption in her care. Her medical team changed, but her social worker, psychologist, and social services supports all remained the same. Next slide, please. So just to highlight also that there were episodes of restraint while in hospital. There were times when she became very distressed, and she remembers being restrained, but now she finds that very distressing as a memory, and it forms the content of some of her flashbacks. She also has flashbacks in relation particularly to the armed burglary on her home. Other considerations would be to think about who are her trusting relationships. In amongst this chaos and poor attachment and repeated difficulty, it's important to think about where her trusting relationships might be. The transition at 18, in our view, was relatively seamless, but I think it still contains some disruption and loss for her. And how have we taken that into account? And lastly, just to think about her side effects and that massive gain in weight and the impact on her self-image and identity. Could we not have anticipated that better? So we've a little time for questions, mainly around clarifying aspects of the history. And if you want to include those in the Q&A, we can try and address those now. We'll have a bit more time for Q&A after each of the presentations and also at the end. I'll just give it a moment for anyone to enter anything into the Q&A, otherwise we'll carry straight on. No, so we'll carry straight on to Miriam next. If we go to the next slide, and Miriam, over to you.
Okay. Peter, there are a few questions now. Do you want to go back to them or no? Okay.
Maybe just I'll cover those quickly. Any diagnosis considered during the 2 admissions? So initially, she was viewed as just having drug-induced psychosis. The impact of trauma was considered, but I don't think PTSD was fully considered at that time. It was only after a second, more long-lasting and perhaps severe episode of psychosis that she was considered to have a psychotic illness. And it was also around that time that there was more inquiry around her trauma, that people started to consider that as part of her diagnosis. There's no siblings, and Arvin's rightly pointed out that drugs are an important part of the presentation and her story now. The restraint, so it seemed that she was quite paranoid about staff, and that was reflected in her behaviour, that she was very distressed, very aggressive, and she wasn't accepting any medication for it. Personality disorder, that's not a current consideration, and any EMDR therapy I'm going to defer until we've talked after Mel's presentation. And hello, Lenny. My relationship with her, I found her particularly enjoyable. I think she's enjoyable to work with. She's someone who really wants to understand and to know what's happened. So professionally, she's very satisfying to work with. Her English is excellent, and we haven't felt the need to have any translator. I think it was part of her difficulties when she first came to the UK, but her English is definitely better than mine. There's no particular family history of ill health. And lots of questions about PTSD, which we will come back to, but and similarly questions about therapy, which we will come back to. And Ray has raised a really valid question around trauma-induced psychosis, which we will return to. Thank you for those questions. I'll now pass on to Miriam. Thank you.
Hi, I think I'm live. Yeah, lovely. Hopefully people can hear me well. So thanks, Peter, for presenting the case. We thought it would be nice to have a mixture of like connecting with the clinical material, a bit of the evidence base, and then going back to the work that has been happening within the Waltham Forest EIS team. So what I'm hoping to do is to talk a bit the trauma and psychosis literature, and then particularly about, as some of you have raised, the issue around psychosis-related trauma, thinking a bit about mechanisms and impact, because that's going to have make us think about how we're going to work with this client group in terms of as a team and also individually, and how we relate to them. And then just a quick mention of a couple of nice recommendations, and then what we are doing in NELFT EIP. And then, as Peter said, there'll be time for Q&A at the end of each presentation. Oh, trying to, so next slide, please. So as illustrated by the presentation, we know that trauma is very common in psychosis. So anything between 49 to 100%, depending on the study, report high rates of trauma, particularly multiple childhood victimization compared to the general population. So people with diagnosis of schizophrenia, 3.6 times more likely to experience those childhood adverse events, but the rates are comparable to other types of clinical diagnosis, such as depression, personality difficulties, or PTSD. Then in adulthood, we know that people also are much more likely to report continuing trauma in the form of violent crime, and particularly the statistics that women are 10 times more likely they experience severe mental illness and to experience sexual violence than members of the general population. So really shocking statistics. So every time we meet somebody with psychosis in EIT, to bear in mind that the likelihood that somebody would have experienced all those things is worth considering. Next slide, please. So Filippo Varese did a meta-analysis a few years back showing that childhood adversity in its different forms is associated with an increased risk of psychosis, the odds ratio of 2.78. And if you have more trauma, you are more likely to have this psychosis, so a cumulative effect. Morgan also identified that the more severe forms of adversity, so threat, hostility, and violence, are more strongly linked to the odds of psychosis. And if you have different types of trauma as well, that also increases the odds. So, the sheer volume of adversity having a bigger impact for people. Next slide, please. So what's the impact? So what should we bother about knowing about these things? So we know that people who have trauma and PTSD have worse outcomes. So they have higher rates of admissions, they struggle to engage with community services, and also have increased severity in the symptoms, both in terms of psychosis and PTSD, and their outcomes around the range of domains are also worse in terms of quality of life, substance misuse, and a range of other impairments in terms of neuro and also behaviors such as suicide attempts that always will cause a lot of concerns. I will slow down, thank you. Thanks for that, Christopher. So next slide, please. So as Peter was saying, I think we thought this will be a good opportunity to really stop and really understand and reflect on the impact of psychosis-related trauma, because by the time people come to us, they likely would have experienced most of the events already. But sometimes I guess we don't stop and realize and think about how impactful those experiences and the treatment can be. There's been a number of reviews around, and we did a discussion around the conceptual understanding of these difficulties. So basically, if you think about the definition by Peter, any event in which you feel that your life is going to be under threat, either physically or in terms of your main identity. If you are thinking that somebody is going to kill you, you have a voice that's telling you that you're going to die, that event, in terms of the way it would be encoded by your brain, would be the same as if you have an actual physical person in front of you. So the way the event would be encoded would be similar, and therefore the likelihood that those experiences would then result in intrusive phenomena and PTSD later on, it's no different. It's all about how things are experienced and how they are appraised. So that's both for the actual psychotic experiences, and then which probably people think less about this, but also in terms of the treatment, as Peter was saying. If somebody has been restrained, I mean, I can just imagine if I was restrained in a hospital and having people, against your will at a time when you're already really frightened and scared of what's happening to you. If somebody takes you to the hospital by the police, when you might be thinking that already you're under threat, all those things are very likely to be experienced as traumatic for people. And some of those events would then lead to PTSD, not all of them, but just a sense of like what we do to people and, in terms of resources, in pressure with our resources, being too tired, not mentalizing about what we're doing to people, how that can have also an additive effect in terms of how those events are experienced. Thank you. So next slide, please. So I just wanted to briefly mention, because those things are going to be true for everybody, but when with certain ethnic groups, that's going to be something we want to be particularly mindful. So a recent meta-analysis suggested that still to this day, even though we had hoped with early intervention services, we're going to reduce this, people who are Black Caribbean or Black African ethnic groups are more likely to be compulsorily admitted to hospital than by white ethnic groups. And although predominantly the population in admissions are men, and obviously it's been a lot written about Black men, I think I was really struck by the statistics that actually Black African women are, in terms of compared to white women, much more likely, 7 to 8 times more likely to be. So something about intersectionality and how the perception of certain behaviors might be playing a part in this explanation. Thank you. Next slide, please. So we just recently did a doctoral in clinical psychology thesis with Samantha Reynolds, and this is a really, I think, moving quote by a Black woman who had been sectioned and who was in EIS. She explains how early in the morning when I was sleeping, they just knocked on the door. I got up and put on my nightdress. That was all. And I went to answer the door, and I saw 8 people coming in. They just stormed in the house and said, "You are sectioned under the Mental Health Act." When I go to the toilet, they're following me. When I go into the bathroom, they're following me. I told them, "Give me privacy. Let me try and just put something on my body, please." Then they were just standing there. They couldn't even allow me to close the door. And I think, I guess, for any of us, the idea of being at home with our bed clothes and having 8 people, the majority of them likely to be strangers, to come into our house and not let us, put sufficient clothes on seems really, unimaginable. I guess we can understand why people did that at the time. I guess there might be concerns about the person's safety. Maybe they didn't want to leave her alone, but the way it was experienced for her was really intrusive. And I think in the end, she had to ask for a neighbor support, and then so that she could gather some belongings to go into the hospital. So I think in that study, people were saying, they might understand that they might have to be sectioned sometimes. And most of them, the reflection was that it was necessary. But talking about compassion and how things are communicated, and I think things could make a massive difference to people of something that's already very distressing. Next slide, please. So we've spoken about trauma, and obviously trauma can have a range of consequences. So this slide is just about the diagnosis of PTSD. So there are very ranging prevalence estimates, so anything between 1216 to 1443 in different sort of studies. So higher than in the general population, but again, it's important to think that not everybody will have PTSD, but they're likely to have other ways of which the trauma has had an impact on them, whether it's in the terms of the content of the symptoms, which we'll talk a little bit later on, but also in the way how they can trust others or not. Sorry, I just lost my... Yeah, so and in specific, looking at PTSD linked to the psychosis, which could be both the psychotic symptoms or the treatment. Again, the estimates are around wide ranging. I think some issues around how that's assessed, but anything from 14 to 47, and also already in the first episode group. As you can imagine, people sometimes it will be the first shock of having come into contact with services. That's something that might be more fresh in people's minds. Next slide, please. So Mel O'Brien, later on, when she talks about her decline in detail, she will present one of the models by Amy Hardy. But here, just to summarize the way, in terms of psychology, how we understand this. So the way it's thought about is, some of the presentations of whether you call it an intrusion or you call it like an anomalous experience, as in psychosis, might depend on the appraisals that the person have of those things. So there'll be a commonality in terms of, a traumatic event might trigger a psychosocial vulnerability, in that when you encode the information, because you're in a high level of alert threat, all the sensory information is encoded, and is encoded in a decontextualized manner. So there is no like narrative timestamp that will help to organize that memory. And we know that the repeated exposure then will create a hypersensitivity to stress. And the sense is whether you might appraise that, let's say you have that hypersensitivity and you're in a situation and you appraise like a voice threat, it could be part of it, the experience of it, whether it's perceived as external, but also whether you appraise it like within your cultural frame. You might be more likely to get sometimes a diagnosis of PTSD, whereas if you don't make a connection, and sometimes you might be shocked to work with people psychologically, where is an obvious link as a clinician about the trauma and the current voices, whether they are auditory or tactile hallucinations, but for the person it would be complete dissociation. And in that case, the person would be diagnosed as a symptom of psychosis. Next slide, please. So here is a sort of a visual summary. I know, sorry, it's a bit of a busy slide, but we just wanted to just put together in terms of organizing a few of the things we've been talking about. So to the very left, we have traumatic events and then sort of proposed mechanisms. And we have obviously biological, will be like the underlying structure where things are happening, but obviously psychological would be what I'll be thinking in my work. So we know that especially you have childhood trauma, that's especially when that's perpetrated by caregivers, that could lead to disruptions in attachment. Also, it might mean that you are less able to regulate your emotions. You might have beliefs about yourself that you are vulnerable, unloved, that you are disgusting, and that other people are not to be trusted, not safe, and that the world generally is not a safe place for you. You might also have beliefs about defeat in terms of comparing with others, and that there is no point in trying because things don't get better, especially if you've been trapped in a situation where things were not getting better for you for a long time. And also you might have learned to cope with adversity by dissociating. If you couldn't escape, you might just detach emotionally and not be present in the experience. The impact that you might see in people in the present time might be people who are fearful, ashamed, they might be detaching, numb, there might be impairments in functioning on how able they are to trust others. And as Peter was saying before, they might cope in different ways. They might, in some cases, self-harm, take overdoses, and then use substances as a way of regulating these emotions because they don't have the skills to do so. And in terms of symptoms of voices, psychosis and PTSD, so we know that voices are particularly linked to sexual abuse. There's been a number of studies linking that, and that sometimes it might be the specific content you see, but sometimes it might be just the themes around intrusion that are reflected. Paranoia has been particularly linked to neglect and bullying in early life. And then we obviously will know the symptoms of pre-experiencing trauma, intrusions or nightmares, or hyperarousal and avoidance. So just to, all these things may be playing in terms of the person you see in front of you who might be smoking cannabis to cope with a range of difficulties or who might not want to come to the appointment. Next, please. So I just wanted to highlight in terms of attachment, just because it's very linked to us in terms of engagement with services. So insecure attachment is highly prevalent in people with psychosis, particularly fearful attachment type. That's when you would like to be close to others, but you cannot because it's too scary. It activates you too much, and then you might cope by that by withdrawing or being aggressive. So you want to, but can't, basically. So that's linked to having poor therapeutic alliance and also poor general engagement and poorer outcomes. And we know that insecure attachment has shown to mediate the impact with voices. Next slide, please. So I'm just focusing just to emphasize that this is not, it might feel innovative and new for some people. And hearing from some of the questions that you have posed, that people who have tried to make changes in service, that's been a challenge for you, some resistance, and you've met some resistance around it. Just to say that, this is something we should be doing routinely. It's in the NICE recommendations, it's in the early intervention standards. We're meant to assess trauma and its consequences with every single person with psychosis we meet. It's not just if it's on the notes a priori, we should just do it with everybody. And if PTSD is identified, we are meant to offer trauma-focused CBT interventions. And in NICE, they group them as a range of them, but I'm just highlighting narrative exposure therapy because it's something we offer in NELFT, also prolonged exposure and EMDR. But EMDR, they make a point of not as a primary recommendation because the evidence is a bit less strong for that. Next slide, please. And just to highlight that there's been some relatively recent research on looking at PTSD treatment in people who have psychosis. So a group from the Netherlands have done really nice trials looking at the role of prolonged exposure and EMDR, and they both are safe and effective in reducing PTSD symptoms. But not only that, people who have these interventions also have an improvement in the psychotic symptoms. So something that shows how there is an interaction between these two phenomena. Important to note that cognitive restructuring is not that useful. So you want to be doing something like exposure, addressing the memories, bringing up the content and updating them. Just talking about things and not getting into the memories is not shown to be effective. And for NET, there's an emerging literature and it uses the same components of exposure that in the first two interventions. Next slide, please. So the trauma screen we use in NELFT is called the TAIL, Trauma and Life Events Checklist. This is a measure we developed with a trainee, Sarah Carr at UCL, and we just basically, it came mostly from a clinical need of thinking, well, there is all these traumas that are linked to, reported in people with psychosis, but there was not one measure that was easy to use that incorporated all the range of trauma. So we developed and validated this measure, and covers both childhood and adult trauma, and includes items of psychosis-related trauma, both in terms of symptoms and also treatment. It's been used in a range of NHS trusts here, and also it's been translated into a few languages and is used also for research purposes. And if you're interested, in a previous talk we did, a couple of our clinical psychologists did a role play on, you wanted to see how it's used in terms of training. And obviously if somebody identifies traumas, which is often the case, then we will complete a PTSD screen also for complex PTSD. Next slide, please. So here you can see a picture of how that looks like. So we have the long version, which is the tail, which is the 20 items I just mentioned, but this is a brief version, but in terms of structure, they look the same. So it's very simple, and people find it not very intrusive because you're not asking them to narrate and give you detail, you're just screening. So you'll ask them if they have ever experienced some of the following items, and they answer yes or no, if that has happened more than once, and the ages, and then they will tell you. We also have an open item in terms of people who want to identify additional things, and then they'll ask you if they have ended less than a month ago, more than a month ago, if they still have an impact on them, and then if so, we will continue doing the screen of PTSD, which I haven't included because probably you're more familiar with that. Next slide, please. And I think this is my last one. So just basically to tell you a little bit about NET. So the reason why we chose it is because the other interventions, they designed to work with one trauma, and you could repeat the same intervention again and again. But the nice thing about NET is it tries to put all the traumas in context. So you can see a picture of what is called a lifeline, where you will construct with the person the range of traumatic events, which are stones, and flowers will be positive events. And you can see a picture of the two people, how they will do it hands-on on the floor together. And the idea is that you will do that to try to create some sense of order. And then you would do the exposure work with all of the stones. And you also talk about the positive events of the person's life. So we thought, given the fact that people with psychosis have multiple traumas, that would be a good way of helping also in terms of organizing the memory, as well as doing the exposure work. So in NELFT, I'm organizing all the EI psychology, early intervention psychologists to be training this intervention, but there are other interventions as well. So EMDR, a few of our staff are also trained on that. And also, even if the person doesn't have PTSD, or if they don't want a full-on trauma intervention for many reasons, because it's a very frightening thing for people to do, we'll still consider the role of the trauma when you do your CBT for psychosis work, and also address the impact that it has on the person's life. I think that's my last one. Thank you.
Thanks, Miriam. Loads of fantastic questions in the Q&A, and far more than we can do justice to, but I'm just going to pick a couple. Chris was asking about the trauma relating to restraint and olanzapine and how we might mitigate against those. And I think my view is just anticipating the really obvious side effects of a terrifying amount of weight gain, and not sitting on that, and just understanding it might have additional impacts on people's identity. And I think restraint, I would hope, is avoided as much as possible, but I think just some recognition that it could be traumatic and is traumatic, and doubly so for someone with a really difficult history as our patient P. And just to acknowledge some of people's comments about culture, heritage, which we've deliberately steered away from because I think it's a topic for a whole webinar in its own right, and we couldn't possibly do justice to that.
So I cannot really read them because so what was the one about the heritage? So you want to pose it?
No, I'll come back to that. Okay. And a question for you then, Miriam. Would you still do cognitive restructuring of hotspots during exposure work with someone who does have psychosis?
Yeah, so I think with NET, that's not what you would do. So the last person I saw, we completed the whole NET intervention, and then we did imagery restricting. which is a different, so I guess with the hotspots, you will update, it's more cognitive, isn't it? You will identify what you were thinking that, and what you were thinking, what you think now in terms of self-esteem, or that's not longer a threat. Whereas the scripting work we're favoring is that in which you go back to the event and you would think, what would you need then? So I think it's more like attachment and needs based. So at that time, what would you have needed? Would you have needed like your mother to come in and say, go away to the abuser? So I think it's got an element, but I guess because it's not sort of like cognitive restructuring, it's less like CBT in that sense. It's more focused around the role of attachment and understanding the person's needs that maybe have not been met yet. So similarities, but not quite the same. I hope that makes sense.
And last question before we go to Mel, would you start trauma therapy while someone's still an inpatient?
Well, I don't think so, because I guess the risk of, I mean, you remember like trauma work is often recommended after the person has not had out of the trauma for 1 month. So I guess if you are still in an environment while you're being in the trauma experience, I think it might be best to just, because it might be that, I guess you could talk to the person and they might be able to, how they're feeling and what they want to focus on. But in terms of any exposure, it might make sense to just give that person time to settle, because some of the PTSD symptoms might just naturally go away. So I guess it's about giving people time to heal naturally, but then if they need to, then offer things.
Fantastic. Thank you, Miriam. And we'll go over to Mel now, please.
Thanks both. I'm just going to share my slides. And hopefully you can all see that. So thanks both. So I'm Mel, I'm a psychologist in the EIP team, and I'm just going to be thinking through about some of the therapeutic approach in this case example, and I guess our hopes and intentions of sort of working in a trauma-informed way in a complex case like this. So I wanted to start by kind of just orientating us to this case example by thinking about how trauma-informed care kind of identifies these practice levels, these sorts of domains that you might be working at in a trauma-informed way. And just thinking about where we sit within that. So you could think of the individual psychological intervention as sitting in this trauma specialist practice, the EIP team and the kind of social worker at the trauma enhanced practice, and then the supported housing at this level here. And like Peter said, kind of key across these sort of domains is that idea that relationships really matter, and that each chance or contact with a person can really be a chance to kind of instill a sense of trust and safety. So in our team, what we really want to think about is how we work with the wider system in trauma-informed care. And, you know, for this client, that sort of meant about thinking about this person doesn't have a kind of current family involved, but identifying who the sort of safe relationships were. And that included the housing manager, who she had a really kind of close bond to, and also the social worker who she'd been working with for quite some time. And so we really want to think about how do we as a system kind of, you know, make this sort of a coherent sense of care around a person. And then in our own team, it was thinking about how do we adapt what we already offer to work for this person in their own context. And so that looked like adapting our carer wellbeing intervention, which is delivered by the assistant psychologist, and offering that to the housing manager. So thinking about psychoeducation around psychosis, and looking at like really common dilemmas between what's an early warning sign versus what's a kind of understandable behavior for an adolescent, and an adolescent who's kind of presenting with these difficulties, and also conversations with a social worker. And then finally having kind of opportunities to meet together in professionals meetings. And when there's a really complex case, it can cause sort of splits in the system where there might be different perspectives on causes and maintaining factors. For example, like the role of smoking cannabis and how that features in the maintaining factors. And so the care coordinator is really central in actually getting these chances to meet together, and not just when things are going sort of badly or there's difficulties, but as a chance to kind of notice what's working well and think about the young person's strengths too. So just speaking now to, I guess, my more individual work with this client, this example. So the care coordinator was really keen that I was introduced prior from that transition to CAMS to EIP. And I think that's a really important principle to thinking about sort of what a transition might represent to a young person with a history like this. But also just being flexible, so starting by just kind of introducing myself by phone. And the assessment itself is a mixture of sort of clinical interview and measures. So Miriam has spoken to why it's so important to kind of screen and assess for trauma and psychosis services. And so using the tail, it suggested multiple traumatic events. And in particular, P felt particularly impacted by some of the incidents in childhood, including the robbery, the sexual assaults, and most recently the restraint when she was in hospital. So how that really connected to the experience of her sexual assault, of being kind of held down. And the PTSD screening measure suggested that they met criteria for complex PTSD, and that at this time there were sort of flashbacks, intrusive memories, nightmares. By the time I had met this client, the unusual experience of voices had ceased, but the distressing belief of being followed, or perhaps her mother having put a curse on her, was still there, although the sort of conviction and preoccupation with it had decreased compared to the time in hospital. So really important to think about the person's own descriptions of their difficulty. So what they discussed was the sense of, not being able to speak, feeling really slowed down, demotivated. And I suppose things that we might look at and give the label to of the negative symptoms of psychosis. But for what this young person, the appraisal she made of that was of being stupid and different. In addition to the sort of flashbacks and intrusions, she described just finding it very hard not to think about the past and the impact of it and why it had happened, and that this would leave her feeling very sad and anxious. And when I met her, there was actually lots of kind of anger in relation to the restraint when she was in hospital as well. And it was really clear for her that the reason she smoked cannabis was that it had been a way to kind of cope with all these distressing experiences. And finally, and a really key one, is this sense of relationships. And like Miriam was kind of alluding to, really wanting them, but finding them really, really frightening. So the hopes and goals here. So whilst she was in CAMS, she identified that she wanted to do a piece of trauma-focused work with the psychiatrist, but also that she wanted to think about ways to manage thoughts and feelings, and to be able to get out more. So starting things like going to college. So I want to now just come back to some really general principles in trauma-informed care that I found really useful to keep in mind in complex cases. So one is that idea of understanding interpersonal difficulties in the context of an insecure attachment. So when someone has experienced a cumulative interpersonal trauma at the hands of caregivers, so losing a caregiver and then having multiple caregivers being abusive, neglectful, we can see how that might disrupt, the attachment development. And thinking together as a team about how that shows up in their interactions with us as services and their relationship to help. So maybe being ambivalent or kind of missing appointments, but us kind of holding in mind, being curious about why that might be. And furthermore, and Peter's right, we could give a whole topic to this, but I think understanding a person in their own context and thinking about the sort of intersection of the parts of their identity. And what I found helpful in this case is really showing a curiosity and openness to exploring these factors. So for example, her own cultural understanding of voices as potentially being jinn and spirits, and kind of making time to think about that together. And to think about what it might be like to work with a white British member of staff, and kind of thinking about, being honest about what I might not understand about her culture and being curious about wanting to. And I think that really can help with developing that therapeutic relationship. And the final one that I wanted to mention, and I think so keen, is really exploring the substance misuse in a kind of nuanced way. So referring to external services if you need to, but also thinking about it together. So validating how difficult it would be to stop something that's felt so helpful for so long, and exploring together the kind of function and relationship between smoking and these experiences. So we watched like a brilliant video that was made by young people talking to researchers at IOP, which we'll link to. And that just opened up lots of helpful conversations. That instead of having this sort of linear, you smoked and you got psychosis, which is what she felt the kind of wider network had said, kind of thinking about this more complex relationship between these factors. So this might look a lot on the page, but I really wanted to present this sort of integrated PTSD and psychosis formulation and to think about it in relation to this case. So what was clear to this client was that the real trigger of kind of getting to the point of being admitted to hospital was receiving this phone call from a man that she believed to be the person that she was married and brought to the UK with. And understandably, this kind of triggered off lots of intrusive flashbacks and memories to that time, but also to her childhood generally. And this was a really frightening experience for her. And so she went back to smoking as a way to kind of cope or numb these feelings, but perhaps we could think that this sort of heightened her sense of hypervigilance and fear. So what this model really thinks about is how, given the neglect, abuse and assault, how someone might have coped with it at the time. And so for our client, there was a real sense of kind of moving between, at times, sort of dissociating and shutting off, and at other times being really hypervigilant and kind of watchful for these men around mum and her sense of safety. And the model also thinks about how the neglect and abuse and the way of coping will have impacted the way the memory was processed. And Miriam spoke about this earlier, but there were some key memories that she described as being like a puzzle and a jigsaw. So she might get kind of flashes of images, of sounds, of smells, for example. And this suggests that her hyperarousal at this time in her life was so high, understandably, in these moments where she feared for her life and feared for her mother's life, that it meant that the memories weren't kind of contextualized properly between the sensory visceral bits and the kind of context of what and where. And this is what kind of leaves these memories vulnerable to becoming intrusions. And in this box here, this scary experience box, we can think of this as sort of being a bit of a mixture of the kind of anomalous experiences of hearing voices, and when she was in hospital, sort of, seeing the faces of men on the staff, and the sort of flashbacks to this time of the sexual assault, but also of these experiences from childhood. And then really key to any kind of psychosis formulation is thinking about the meaning made, so how someone might have understood what these kind of unusual experiences mean to them. And the model considers how these appraisals are both influenced by how someone copes, so their coping style, smoking, kind of being really watchful, but also the sort of semantic meaning they made at the time of the abuse. So for P, really, seeing herself as bad and deserving of this punishment, and that others are untrustworthy. And we can really see how that might influence the kind of meaning she made from these intrusions and anomalous experiences. So this model can be used to think about targets for intervention alongside the kind of client's goals and hopes. And so, one kind of target might be about the more maintenance factors. So really thinking about what a person does, their kind of coping styles. And in complex developmental trauma, the kind of skill development of emotion regulation is disrupted. And so it makes sense why someone might use kind of substance misuse, avoidance, but also working at the kind of appraisal level. So thinking about how to sort of maybe influence or be more flexible in these appraisals. And then, of course, the reliving work itself, when there's kind of indication of fragmented memories, as in this case. So what this has looked like is a phase of kind of promoting control and emotion regulation. And I can't speak to all of this, but lots of sort of psychoeducation and thinking about what these labels like psychosis mean to this person, but doing lots of psychoeducation about how trauma might affect our memory, and doing sort of understanding links between our thoughts, feelings, and behaviors. And I just wanted to include an example of a coping card we made together, because breathing was one of the most sort of, successful and like surprising things for her about how much she found it helpful. And then, like Miriam spoke about, the next step would be the reliving works, the narrative exposure therapy, and trying to create a consistent narrative when for so long there hasn't been one. And the aim of this is to integrate those kind of hot and cold bits of the memory. And that's by contrasting between the kind of hot memory back then, so the cognition, the emotion, the physiology, and what they know now as well. So I've given you such a whistle-stop tour there because of time. I wanted to finish with some final reflections. And I think for me, when working with a case like this and in complex trauma, it's about really working together as a team, both in the kind of formal network meetings, professionals meetings, but actually the care co and I just speaking a lot about what it's like to work with this person and just kind of trying to keep in mind parts of this formulation. Another one is pacing. So not only does this person kind of have, some unusual experiences, flashbacks, intrusions, but feeling very slowed in their thinking and finding it hard to kind of, find the right word that they want to say. And so I think having lots of summaries and checking in, and it's easy to assume someone's kind of got what you're saying, but just making lots of chances to kind of hear what they've heard and what I've said. And then finally, and most importantly, perhaps, is supervision. So to think about competency and adaptations, but also to think about the fact that actually working with this kind of case and kind of witnessing, these really awful things that happen to people in their life, can just be a lot on a therapist. And so really kind of using supervision to think about that. So thank you. Peter?
Thank you, Mel. That was really helpful. Definitely a whistle stop, but really helpful. And then there's lots of really good feedback in the chat as well. So we've very few minutes and way more questions than I can possibly do justice to. But I'm going to pick up just a couple of questions. Miriam, is I think a question for you, that someone said that when they've delivered trauma-informed care to staff, a number of staff have begun to recognise their own unresolved trauma issues. What would you suggest as ways to respond to that or address it?
Well, I think something we do in our training is like alert people at the beginning and not have an assumption that even now us or people in the audience would not be affected by the things that have been reported. So just being mindful and also if give people the option, you know, if they feel affected by this, they can come and talk to a member of the psychology team, and we can think of whether there are, you know, in terms of well-being of staff, referrals and things that might need to be addressed, because obviously it could be something that has happened in the previous personal life, or it could be something that happened as a result of the work that we do that can be also very challenging. And obviously we know very well with COVID, colleagues reporting high rates of PTSD. So I think obviously it can happen also in the work in the inpatient unit.
Great. And someone else had asked about their difficulties in trying to generate interest in trauma-informed care and training across their trust. And they'd ask, they had a sense it was a bit of a power struggle from very senior management. What advice would you have in terms of trying to persuade people of the relevance of this area and training in it?
I mean, I think understanding the evidence is a first step, and I think also people might still have old-fashioned views about there are things like either or, it has to be PTSD or psychosis, and people can have comorbidities. And having, I mean, the understanding the role of the environment on mental health difficulties is something that is not new, but I think maybe it's gathered more momentum recently. So I think you know, patients, meeting with people beforehand and understanding where they're coming from to match the training, and I guess taking one step at a time. It might be that you can just start with doing trauma screening, and then understanding how that's so prevalent that make people think actually we should be doing something about it. So I think just dialogue and understanding where people are coming from. I don't know if, yeah, that would be my personal.
Thanks, Miriam. If we can just go back to the slides, and I'll just pick up on that as well, please. If we just go back to the last couple of slides, please. Thank you. So I'm just going to close, but touch on something Miriam just said as well. But I think thinking about trauma is everyone's business. I think the tail or Minitail should be routinely used. And that aspect of our approach needs to be patience, flexibility, and adaptability. I put just two references there. One is transforming psychological trauma.scot. If you were to put that into Google, it comes up with a really amazing array of training packages and touches on the levels of ability that Mel alluded to. It's really useful, and it is definitely a whole team training. And there's also the YouTube video, which Mel mentioned, which is a recording of a group of school children, sort of A-level students with researchers, and just talking about drug use and the ways in which talking about it would make sense to them. Next slide, please. And just to say a huge thanks to Miriam, Mel and Ruby, and another of our colleagues, Dr. Maiwa Aina, who's been supporting us in the background. I want to say a quick thanks to our EI team and our service users across NELFT. And lastly, a thank you to Katie and Kesia, who've been pulling the strings in the background. And just to thank you to you all for joining us today. I hope you've taken something from it, and have a good evening.